When we look at factor 12, we're looking at occlusal plane. And again, as you're going to see, occlusal planes can have a lot of variation, but the thing that we have to think about an occlusal plane is we want something that is aesthetic, something that looks nice, but also will function in a way that we can have posterior disclusion and anterior guidance. So just from a standpoint of just reference, there are a couple of terms that you should have some familiarization with. The first is the curve of Wilson. Curve of Wilson basically says that if you took a ball with a 4-inch radius and put it on the mandibular teeth, you'd see that the buccal cusps were a little taller than the lingual cusps, and then it would drop down a little bit, and then it would come back up. So there is a definite curve from this perspective. If we look at it from the profile view, we're seeing the curve of Spee, again, is a ball with a 4-inch radius that starts at your canines, follows the buccal cusp tips on the curve, and then goes right up through the condyles. Now, again, this is from the literature. The idea here is that when you have a teeth oriented this way and we close on the arc, this is going to be the best way for forces to go through the long axis of the root. And this certainly works as we think about arc of closure. But we think about curve of Wilson, and again, people tend to chew in an elliptical pattern. They drop open, they go to the left or the right, and they come back on an angle. And so if you think about maxillary teeth being tipped out a little bit, mandibular teeth being tipped in a little bit, as we come back on the chewing stroke, that also puts forces through the long axis of the teeth. So here again, does it have to be perfect? We think about ortho tends to level occlusal planes. It still tends to work, right? Because again, both of these options allow for us to be able to create interference-free occlusions, which is exactly what we are after. But having these little tips and looking where roots are in the bones, one of the things I love about CBCTs, if we're thinking about expansion, we can look at where the roots are in the bone from the frontal view, where they are within the buccal and lingual plates, and start thinking about, is expansion going to be dangerous by pushing the teeth through the bone? Again, we start thinking about this concept of the curve of Wilson, where we have the lower buccal cusp a little taller than the lower lingual cusp. And while in a working movement, we can have canines that are slightly steeper than this, and we can easily get guidance. This little shorter lingual cusp really helps this from not getting caught here, a lingual to lingual interference. And as long as our canine guidance is steeper than this slope here, it should disclude as well. The problem becomes in the other direction. And I've mentioned this before, that when we have the longer buccal cusp that has to get past the longer lingual cusp on the balancing side, so imagine that this is a left working movement, this is the balancing side. And as we start thinking about that, in a left working movement, that condyle on the right side cannot move medially without coming down. And so that, in fact, movement, that condylar guidance, if you will, on that side, definitely helps with the disclusion. We don't have the balancing side lower buccal cusp moving medially. They actually move down, following the path. So anterior guidance on the left with condylar guidance on the right is what helps us disclude those posterior teeth. And again, just having an understanding of this 4-inch curve, where the curve extends through the condyles, this is what classically gets us to think about getting the arc of closure, the closure of the jaw, and lining up the roots to put the forces through the long axis of the root. So as we start to think about this, there's been some pretty cool ways. I learned this at Pankey years ago, the Broderick flag that still many dentists utilize. And again, we don't really have that in the digital world right now. But we do have the ability to visually look at occlusal planes. And what we just have to understand that if we have really exaggerated curves of Spee, or potentially if you're missing an upper molar and a lower molar goes into that space and it's real irregular, you can see that a missing upper molar and an extruded lower molar, as the jaw goes into protrusion, there is going to be protrusive interferences. So, we just want you to understand that primarily your occlusal plane should have pretty level cuss tips. We don't want it candid with the eyes. It should be nice and level, that whole maxillary plane. It should be pitching up slightly to the posterior. And it should allow the anterior guidance to do its job. So, all this analysis that we do, just think about looking at it from a visual standpoint. And if it allows the anterior guidance to do its job, then we're going to call it an acceptable occlusal plane. We look at factor number 13, and we're going to call it the neutral zone. I think understanding the neutral zone is one of the most important things that we have to do. And these last two are really about how the muscles can affect the horizontal position of the teeth, which is neutral zone. And when we start talking about vertical dimension, how that affects the vertical position of teeth. So remember that the horizontal and inclination of teeth is related to muscle. These bands of muscles, the orbicularis, the three bands of the buccinator muscle that go all the way back to the pterygomandibular fa, are these complex of muscles that put force on the facial aspects of the teeth, and the tongue puts the outside force on the teeth. And so if we think about it, what's really interesting about the neutral zone is that it was there before the teeth were, and so it's the pressures of the lips and the pressures of the tongue that guide teeth in position. That's why if we have situations like if somebody can't breathe properly through their nose, they start breathing through their mouth, their palate starts to get up, move upward, right? Now air coming through the nose, that narrows the upper arch, and that kind of creates cross bites and overjet relationships and all sorts of things. So we can start looking at just scans or models and looking at tooth position and start imagining, like in this class 1 patient, where the lips are. We can imagine where the tongue is. We have a good idea of probably the width of the arch. And so if we start looking at the models and then putting the lips on the models, we can start to see in these type of patients, the lips can easily seal, and behind the teeth that there's going to be also a tongue. So every time we swallow, our lips come together, there's pressure, particularly this lower lip, how it puts pressure on that incisal edge, the incisal third, to create that seal. And as we swallow, the tongue comes forward and there is that space. In this same patient, we should visualize that the tongue has access to the roof of the mouth, so that the band of the orbicularis and buccinator muscles go around the jaw, upper teeth from the outside, but the tongue is also filling that space going up into the garage, and the two put an equal opposite force. So, as we think about ortho and expansion, and we're worried about expansion not being stable, well, if we can get it expanded enough for the tongue to go up there, then it's a pretty good situation. Again, start thinking about where the muscle is the tightest. Back here, where that band is coming around that second molar, we've all been back there trying to hold that lip back on really tight patients, and we can have a real firm affinity for how all that affects. We can also understand how neutral zone and getting the teeth over the ridge on a denture case is so important. We get the teeth too far one way or the other, and we're not going to have a stable situation. Now we start thinking about the young kids that don't breathe properly, that can't breathe through their nose, and they develop this type of narrow palate where the upper jaw is too far forward, and we start thinking about how do these teeth stay in that position? Like, where are the lips? Where's the tongue? The tongue often can't get into the roof of the mouth. It's often sitting on the teeth, so that's going to mean there's outside pressure from the teeth, and the pressure from the tongue is more in this direction. So there's no wonder why we end up with this high palate, and it stays like that high vault. The other thing we start to see is up front, the reason those teeth are relatively, I hate the word stable, but unattractive, but can be stable from a neutral zone perspective, is the patient can't really bring their lips together. They have that sort of bucked look, and the facial aspect of the lips are here, and the lower lip is kind of smashed behind these upper teeth. And so changing that becomes challenging. So we've got to look at it, and orthodontists are looking at SEPs. We're going to look at our scans on a virtual articulator. But our treatment rationale for expansion, whether we do it on a young kid or on an adult, if there's a SARPE or you're using temporary implants in the palate and moving the whole thing, but if we can expand it enough for the tongue to get up into the roof of the mouth, changing the shape from kind of like an alligator type look to more of a U shape, once the tongue's up there, we can have great stability because of the outward force of the tongue. We're changing the neutral zone. And again, as we change that arch form, usually the upper jaw comes back, and we end up changing the neutral zone in the front of the mouth as well. Thinking about Ben here, and as I examined him, one of the things I mentioned in his case was that with these type of wear patterns, when you see a pseudo class 3, often what's happening is as they destroy their lower incisors and they're destroying the upper incisors, what creates the pseudo class 3 is as they're grinding, the lip is actually putting pressure on the teeth and they finally just grind through the edges. So they end up with this edge-to-edge sort of pseudo class 3 relationship. The wear is fast enough, they also might be losing a little bit of vertical dimension as well. Talk about that in a second. But, as I looked at him, what really made me want him to change his vertical was I wanted space, so I didn't have to cut any tooth structure away. And I was also recognizing, since that this is back, I'm probably not going to prep really anything off his front teeth other than make a margin. And if we open the vertical, I'm going to build all that up. But sometimes we have to cut a little bit more off the lingual to have a normal shaped tooth. So I want to be very specific about where I'm visualizing I'm going, but understand wear and tear changes the tooth position horizontally. And of course, we're also seeing change in the position vertically because of compensatory eruption. But wear and tear, tooth wear, remember, creates tooth position problems. And neutral zone is going to affect where the tooth goes from a horizontal perspective, which is what you need to think about in your design. Remember when I did the first iteration of temps, I looked at it and I brought it out, but I even wanted to bring it out a little bit more. Why? Because the shallower we make his guidance, the smoother his guidance will be, and often the most comfortable and stable that's going to be long term. So just visualize as you look at the relationship here, how opening his bite is going to bring him down and back. I'll be able to add to the front of these facial. We're going to be creating more overjet. But the reason for that is I'm trying to put the teeth back where they were from a horizontal perspective before the wear and tear and the pressures of the lip sort of lingualize things. So studying your cast can really help you see some of this. So just visualize then, when we think about neutral zone is incredibly important as we look at where the teeth are horizontally from the pressures of the lips and the buccinator muscles and the pressures of the tongue outward. The 14th and final factor of occlusion every dentist must know is vertical dimension. And a lot of interesting theories about this. I'll sort of talk to you first about what I learned from Dawson and Pankey and Spear and Coyce and all the greats along the way. And then also some of the other theories that are a little bit more more recent that question some of those concepts. But the one thing that I will just say is that sometimes when we have this conversation, we're misconstrued thinking that we are saying that you cannot alter vertical, and you absolutely can. right? Vertical is unrelated to comfort. If we do it in centric relation with equal intensity contact all the way around, we have a lot of abilities to change vertical on that arc 2 to 3 millimeters and gain all the space that we need. And as you'll see, if we do it in centric relation, if there's a slide between CR and MI, it even makes it a little more predictive. But the first thing, just looking at vertical, that I want you to realize is that we do measure it from kind of the nose to the chin in the patient's own habitual occlusion. And the other thing that we're going to also say is that this vertical dimension is related to muscle. Okay? Why do we say that? Why would the muscle be related to where the teeth are kind of in a vertical position? Well, the first thing to think about is the muscles were there before the teeth were there. And if we think about the space between the nose and the chin, that space is generated by the 3,000 times a day we swallow, where we create this vertical position between the chin and nose that's very, very repeatable. And when teeth erupt, they basically erupt into that position until they meet an equal and opposite force. And as we know, that we never lose the capacity for that. So if a tooth is removed and the lower tooth, it's not restored, the lower tooth or the tooth below it is going to start shifting position until it meets an equal and opposite force. So this first theory basically says that it is the repetitive contracted length of the muscle that determines that position, that vertical position in space that we call the vertical dimension of occlusion. So remember that the repetitive contracted length of muscles determine this mandible to maxilla relationship, and that relationship is going to be consistent over time. And one theory suggests that if you, even in rapid aggressive wear like we saw with Brian, that you do not lose any vertical, which is shocking to some people. When I look at Brian, he definitely looks like he lost a little bit of vertical, but he may have always been like that. But the first thing that we'll just say, and there's some studies out there to show this, that even in rapid abrasive wear does not result in a loss of vertical dimension. So I mentioned vertical dimension is not related to comfort. And remember, when we change vertical, we don't unload the joint because we're just arcing. The joints are behind the muscles, they're behind the teeth. So putting anything on the teeth or putting a splint in there doesn't force the condyles down. It just causes it to rotate. Now, the one thing that we can do, we can hope for, and I'll say this another way before I get there. The other thing we're going to say is that if we open the vertical dimension and we're centric relation, that we do stretch the muscle a little bit, right? So if we build the occlusion more open, one theory is that if we open the vertical dimension and we do it all the way around, the patient won't know it, but it'll go back to the original vertical. There was McAndrews studies, orthodontic studies with serial cephs that suggested that. Unpublished work, but stuff that I've heard about in lectures that is intriguing. So one way we can open vertical dimension without affecting the length of the muscle, which would be beneficial, is when a patient has a slide between CR and MI. Because remember, in maximum cuspation, if this is the length of the muscle, the condyle goes back to centric relation. We can often gain space to work on their teeth, but because in maximum cuspation we're down and forward, because the condyle is pivoting up and back, the muscle sort of just shifts in a sling. So this is great because, and I'll just say this, that if you have a slide between CR and MI and you can do all the work, the addition to the teeth in that space, you should have very minimal effect on the muscle and no concern about the patient going back to the original vertical. Now, what I said earlier is if you do this and the patient is adapting for 6 months and they don't know it, what's the problem? What the problem is that sometimes there may be little changes to the occlusion and things that I might have to fiddle with and to temporaries or restorations. We got to keep a little bit of a closer look on it. It's not a problem. We do it all the time. But if I have the CRMI slide thing, I can treat this patient as a pretty normal patient. Go ahead and put the provisionals in, go right to the finals. If the patient has ground themselves into CR and I have to open the vertical, then I might keep them in temporaries for 3 to 4 months longer than I normally would, and then start finishing things. So the question then becomes, is it safe to open vertical? And I've already told you it is, but this is the classic work from, actually this is the more recent work, 2000, let me back up one. The more recent work that was in Clinical Cosmetic Investigative Dentistry Journal that basically is saying that they believe that it's not so much the change in the alveolar process, the adapting of the bone, like Dr. Dawson and the Pankey Institute and others have talked about, that it's actually adaptation of the muscle. That's what they think. Dawson, in his book in '89, did a great chapter to read. He basically believes that when we open vertical, what's actually going on is the alveolar processes are shortening or lengthening depending on we're opening or closing. That the muscle length is always going to go back. So if we stretch it, the alveolar process will go shorter. So people that are wearing their teeth and the teeth are erupting, the alveolar bone and everything comes with it. We know that happens. So all I would say is I don't really care which way it is. I know from a clinical perspective, we change vertical dimensions all the time. And what I'm doing when I'm looking at a patient like Brian is seeing if I need to do it. And what you have to remember is when you look at a case like this and you find it beneficial, you just can't open this segmentally. You've got to open it all the way around, at least in one arch. And with him, remember, I did toppers on the molars. We did crowns, first bite to first bite. We did bonding, first bite to first bite on the bottom, injection molding, and then I did some freehanding bonding where he had some of the potholes on the bicuspids and first molars. But we're going to plan for that. And changing vertical allows us to have the ability to have the freedom to add the teeth, to get the cusps where they're supposed to be, get the fosses where we're supposed to be. And if we have those equal intensity stops, and we can also then have non-interfering posterior teeth and good guidance, then we have control over the occlusion. And so with that, just think about neutral zone being the thing that's controlling the position of the teeth horizontally, and that vertical is controlling the position of the teeth vertically. We have freedom to do some work with all of those things. I get asked a lot, how much do I need to open? I'm going to open the least amount that I need to be able to get the job done. I hear things about opening, 8 or 9 millimeters. I don't know how that's possible. I don't think I've ever opened at the pin on an articulator, analog or virtual, more than about 2.5 to 3 millimeters. That should be plenty. So that's been the 14 factors. And I think it's interesting now to go back and to take a look at which factors did we utilize in the planning and execution of Brian's case. And certainly we had to think about the temporomandibular joint. We got a lot of information about range of motion and load testing and joint sounds and history to know that he did have a stable, healthy joint. We certainly used centric relation as our condylar position. Was not going to use his own bite, not going to use MI. And he did not have a need for adapted centric posture, so we didn't have to use ACP for him. I certainly had to understand the role of muscle. I certainly had to develop occlusal contacts or stable holding stops. I certainly had to understand anterior guidance, and as part of anterior guidance, making sure it was steep enough to disclude the back teeth, but still in harmony with the envelope of function. So overbite and overjet, freedom from centric, and envelope of function were all a part of that, dialing in and visualizing and in our execution of the case, making sure that we had that dialed in. We also worked out the crossover in our planning, in our provisionals, and in our finals. We did not need to use group function. He had good, stable canines. I certainly had to think about as a co-occlusal plane. I changed it all. We talked about neutral zone, the fact that It brought his the pressure from the lips, from the destruction of the lingual aspect of his upper teeth, brought those upper teeth back. So we had to build him back out. And I definitely need to have an understanding of vertical dimension. So as we think about these 14 factors, it's taken me a career to really have a good understanding of this, and hopefully this is a first step for some of you to get really curious and make sure that you have a great understanding. In your bread and butter dentistry, you're going to be utilizing these a lot. As you start doing bigger cases, you're going to utilize more and more of it. And remember, whether you're working analog or digital, these principles do not care which way you go. They just care that you pay attention to it. And I think if you can start applying these principles to the digital workflows, you're going to be able to do things much more efficiently, more accurately, have a lot of fun, and make a lot of people happy.